Thank you all for joining us today, and welcome to our ATS Thoracic Oncology webinar, Lung Cancer Screening for Individuals Who Have Never Smoked. I'm Gerard Kim, the chair of the ATS TOA Early Career Professionals Working Group and assistant professor of medicine at the University of Pennsylvania, and I'm joined by Jeremy Mudd, a postdoctoral research fellow at Mount Sinai. Together, we'll be moderating today's discussion. Before we get started, we just wanted to remind everyone that this is a live event. It will be recorded and uploaded to our Assembly website at a later date. And if you do have any questions throughout the webinar, please place them in the chat, and we'll try to address as many as we can during our time together. As a reminder, the views expressed during this webinar are those of the speakers alone and not necessarily endorsed by the ATS. With that being said, I'm very excited to introduce our lung cancer screening expert panelists who will be sharing their insights with us today. They represent some of the world's leaders in the field, and we are truly honored that they have agreed to participate in this webinar. Dr. Lecia Sequist is the Landry Family Professor of Medicine at Harvard Medical School, the Program Director of the Cancer Early Detection and Diagnostics Clinic, and a world-renowned thoracic medical oncologist. Welcome, Dr. Sequist. Dr. Yeon Wook Kim is an assistant professor of pulmonary medicine at Seoul National University Bundang Hospital in South Korea, a member of the International Association for the Study of Lung Cancer Multidisciplinary Committee, and an international pulmonary leader in lung cancer in Asia. Thanks so much for joining us today, Dr. Kim. Next, we're happy to welcome Dr. Gerard Silvestri, the Hillenbrand Distinguished University Professor, Senior Vice Chair of Faculty Development at the Medical University of South Carolina, and Section Editor and author of the American College of Chest Physicians Evidence-Based Guidelines on the Diagnosis and Management of Lung Cancer. Thank you so much for being here, Dr. Silvestri. And last but not least, we're joined by Dr. Jeffrey Velotta, a thoracic surgeon at Kaiser Permanente Oakland Medical Center, assistant clinical professor of surgery at the University of California, San Francisco, and leading lung cancer surgeon scientist. Welcome, Dr. Velotta. Before we dive into discussion topics, I'll provide a high-level overview of some salient issues relevant to today's discussion. So first off, lung cancer in individuals who have never smoked is the 7th most common cancer worldwide, and it comprises approximately 25% of all incident lung cancer diagnoses. It's also the 5th leading cause of cancer-related mortality worldwide, and most cases are incidentally detected because smoking history is a requirement for most of the world's lung cancer screening guidelines. I pulled this table from Dr. Silvestri's very recent JTO article, and just highlighting that most of the different countries in the world do require some sort of smoking history in order to be eligible for lung cancer screening. So among those who have never smoked, a lot of the risk factors are some of the ones that we're pretty familiar with: age, family history of lung cancer, personal history of cancer, secondhand smoke, environmental exposures. And then we'll get to some of these, but potentially Asian ethnicity and female sex as well. And a lot of this data comes out of Asia. Yeon Wook is actually one of the folks who has prominently published on this issue. There are a variety of different risk assessment models that have been developed by a variety of different folks that are meant to try to identify quote unquote high-risk individuals among people who have never smoked. The major challenges with implementing such risk models is trying to determine what the appropriate risk threshold is and whether or not these different models are generalizable from one population to another. And just in kind of overall speaking, if you have a population with lower risk of the outcome, and in this case, among all people who have never smoked, the risk of cancer, of lung cancer, is definitely lower overall than among folks who have smoked. And so this kind of does bring up a lot of questions as far as what the threshold risk should be for screening. And there's also questions regarding to what extent lung cancer in individuals who've never smoked actually represents a biologically distinct disease entity compared to lung cancer in individuals with a smoking history. So some of the known risks associated with lung cancer screening in general may be actually amplified because of this reduced overall risk among individuals who have never smoked. So things like radiation exposure just from getting low-dose CT CAT scans, the concepts of false positives potentially resulting in unnecessary diagnostic procedures, this concept of overdiagnosis, which I'm sure we'll be discussing at some point today, otherwise also known as potentially pseudo disease, which really reflects potentially clinically insignificant disease, lead time bias, which is early diagnosis without an actual change in disease outcomes downstream, and then length time bias, which is distinct, which is just the concept that screening might be detecting more indolent disease as opposed to more aggressive, life-altering disease. And so I'll finish with this figure that Dr. Silvestri included in his recent article that was actually adapted from a different article that Dr. Silvestri published along with Patricia Rivera and others, which really, I think, is really nicely encapsulates what we're going to be discussing today. On the x-axis, you see risk of lung cancer, which increases, from left to right. And on the y-axis, you have the benefit of screening. The idea being that you have to have a certain amount of risk of lung cancer in order for the benefit of screening to be worth it, so to speak. And of course, like we mentioned, among individuals who have never smoked, the risk of lung cancer is lower. And so the question is sort of, what should this threshold be for that the risk-benefit ratio makes sense and is sort of worth it, so to speak. And so with that, we're going to launch into some of our discussion questions. So I'm just going to stop sharing right now. And so just to start off our discussion, like I mentioned, observational data have indicated that lung cancer in individuals who have never smoked appears to be more common among Asian individuals living in East Asian countries such as China, Taiwan, Japan, and South Korea. It's been hypothesized that this is likely due to a combination of genetic and environmental factors, as individuals of East Asian ethnic backgrounds living in the United States appear to have lower lung cancer incidence compared to their counterparts residing in Asia. So, how should we interpret study results from Asian populations when assessing lung cancer risk among individuals who have never smoked living in the United States and other Western countries? And for this question, we're going to start off the discussion with Yeon Wook.
Yeah, I think the apparent regional difference in lung cancer incidence among the Asian population perhaps reflects our current knowledge that multiple risk factors other than smoking would be associated with lung cancer among the Asian ethnicity, including genetic, environmental factors, occupational, and other prevalent pulmonary disease like tuberculosis. So when we look at different countries in Asia, different demographics and characteristics do appear from country to country. For instance, the Eastern countries that you mentioned are characterized by a rapidly aging population and high accessibility to opportunistic CT scans. And other countries like India or Indonesia are suffering from a high level of air pollution and a high prevalence of tuberculosis. So there would be many factors, and including geographic when we consider lung cancer in never smokers, even for the Asian population. And I think identifying the relevant risk factors that can be implemented in lung cancer screening is what many researchers are trying to do and working on.
Lecia, I see you nodding. Would you like to follow up that discussion?
Yeah, sure. I mean, I think it gets to a larger conundrum, which is that we don't have a great handle on risk factors for lung cancer in general. I think we have convinced ourselves, and certainly when we all went to medical school, we learned about smoking being the major risk factor. But I think that data that's coming out over the last 10 years is really reshaping that to, of course, smoking still is a risk factor, but it's certainly not the only risk factor. And we may have been too quick to assume that everyone who has received a diagnosis of lung cancer who also happened to have been exposed to cigarettes in their life, that must have been the reason. The truth is probably much more complex. So I think perhaps at the root of this question is that we don't really have a very good test or calculator or what have you for telling who's at risk for lung cancer in general, and that could be something that could be hugely useful when thinking about who to screen.
So yeah, no, that was great assessment from both panelists. I think the thing that is true is that if you look at a lot of the lung cancer screening in never smokers, right, 13 out of the 14 of them, and as Gerard knows, is from Asian countries. And so I look at it as kind of a more glass half full thing, a positive thing, that yes, while Yeon Wook is correct, there's we think there could be differences even between different Asian countries, but regardless of Asian, whatever ethnicity, race, ethnicity, I think it needs to be looked at in other countries. For example, the United States, right? So we know in the United States, in a certain Asian population, that there was an increased incidence in lung cancer detection. Elaine Chum's group showing 1.5% lung cancer detection rate. And again, this was just screening. We don't know about mortality. We don't know all of that beyond. But I do think that it does need to be looked at because, for example, what we saw in Northern California when we published last year in CHEST actually is that there is an increased incidence in lung cancer in never smokers in the Asian population. Now, it's not to say that this is not about just Asian Americans and Asian or people from Asian descent. It could be, we're talking about it just lung cancer screening in general. But when we looked at all the different race, ethnicity, we did see an increase in incidence. And this is in our population in California, that it was rising because we do have a good denominator in our system with good smoking history. So it is something to think about, that it's not just some of the factors that we see in Asia and Korea. We are seeing it in high populations like in California too. So I do think it could be a call to action to be looked at in other parts of the country.
I wonder if I could jump in. Thank you for those comments. I think we have to separate two really, really important factors here, which is the difference between risk models and risk of developing lung cancer and lethality from lung cancer. And so when we look at all the models that are starting to be developed in Asia, where, for example, the risk of developing lung cancer, if you have a family history, genetics, is 2.6. But if you go back to even Dahl in the 1950s, the lethality from lung cancer was 13 times higher in smokers than in never smokers. And if we look at the data from Sony in 2001, where he sort of just randomly did 500 CT scans on heavy smokers and 500 in never smokers, he found the same incidence. And so that in some ways cannot translate to a lethality difference. And so while I think these risk models can inform us about the potential for that increased risk, all they do is help inform us about what should be tested, in my opinion, in a randomized setting to see if that risk translates into a mortality reduction. Remembering that, Jeff, if you come to me with a sore throat and I treat you with an antibiotic, you and I assume that risk. You assume the risk of an antibiotic that may cause a rash or may give you renal failure, but you assume that risk, and I assume the risk as a physician of treating you. In a public health sphere, we are exposing a population, a full population, most of which, probably at least 98% of which, will never develop disease and can only be harmed, even if that harm is minimal, and can only cause tremendous cost to the healthcare system and anxiety among certain patient populations. The level of evidence there, I believe, needs to be higher. And I think these risk-based approaches are good in identifying who might be at risk, whether it be tuberculosis, whether it be family history, whether it be asbestos, whether it be biomass cooking fumes. Then they need to be tested to see if, in fact, screening that population with that risk leads to a mortality reduction. One last thing I'd say is, I've been at this longer than everybody else because I have no hair, 30 years. And when I started in this profession, I never thought I would see a lung cancer that might not cause death. Everybody I saw was advanced disease, and most of them died. Early stage was picked up incidentally in the emergency room. But we are seeing tons of these ground glass opacities, either incidentally through the emergency room or through screening efforts in populations that are not at very high risk. That's something we need to consider. I never thought I would see this, nor did I think people think they would see this in thyroid cancer, in breast cancer, and particularly in prostate cancer, where you could live with the disease and not die from that disease. So I would leave it at there for now.
Thank you all for those really thoughtful responses. And actually, it's a great, Dr. Silvestri's comments are a great transition into our next question. So several risk prediction models have been developed in an attempt to identify high-risk individuals who have never smoked and may therefore benefit more from lung cancer screening. However, due to the inherently lower risk of lung cancer among individuals who have never smoked, several investigators have concluded that the benefit of screening this population would likely not outweigh the risks. How, if at all, do you think future models for these risk predictions can be optimized to better identify high-risk individuals who have never smoked to make lung cancer screening a realistic possibility? And then, just as a bonus, which current models, if any, do you consider to be more effective, or would you consider for use in your own practice? Maybe we could start with Dr. Sequist with this one.
Sure. Well, I think that in general in lung cancer screening, we don't have a component of risk adjustment built in even to the current, USPSTF. I mean, of course, if a nodule is seen, we do have risk assessment of that nodule, and are we going to biopsy it or follow it in 6 months, what have you. But just in terms of if you come in for lung cancer screening and there's no particular nodule of concern, everybody gets the same recommendation, which is come back in 1 year. And, I think if we're going to think about expanding screening to other populations, we have to do that hand in hand with some sort of risk adaptation of our frequency of screening. This is how we do other cancer screenings. If when we do pap smears, we also test for HPV, and depending on the results of that risk stratification test, you may require a pap smear more or less frequent. Colon cancer, if the first colonoscopy doesn't have a single polyp, you will have a different recommendation than if there are multiple benign polyps. So we just don't have anything like that for lung cancer, and we need to, especially if we're going to think about increasing the screening population, because there are people who are at very low risk for lung cancer and do not need to be screened every year. The problem is we don't know how to tell who those people are and who are the ones that, despite the lack of, for example, smoking exposure, are at high risk. So we need better tools, and I don't think we have one in clinical use today. I'm doing research on a particular AI model that we hope can serve this function of telling us who's at risk, which is the Sybil AI algorithm. But I think that I think more tools are needed in this space to tell us about risk.
Yeah, I think, at our place, I screen in 7 hospitals throughout the state of South Carolina, and we individually use the PLCO M2012 model and provide that information to each patient to let them know what their risk is, and given their personal preferences. I would say more than 90% go on to be screened unless they have severe comorbidities. So we find the model useful for patients, particularly elderly patients who might say, if you can show that they'd quit 14 years ago, for example, that their PLCO risk is less than 1%, they may not want to go through it. On the other hand, some people who are hesitant, who have a risk of 15% in the next 6 years, it is a really good way of both having them access screening, but more importantly, getting them to come back. If we say, hey, look, even if your scan is negative this year, you have a 15% chance of developing cancer in the next 6 years, really might want to get back here next year for your follow-up scan. So that's how we use it. I can tell you that other countries are using it as a cutoff. So for example, Canada, parts of Canada and the UK are using 1.5% as a cutoff, and they won't screen folks below 1.5%. Above 1.5%, they will screen. And there was a great paper recently by Martin Tamamagi's group in Nature Medicine that looked at the really safe screening and the cancer detection rate that they picked up using those criteria. Is that good enough, though, to identify never smokers? I would point to 2 papers I think are incredibly important. One was actually Martin, who used the PLCO M2012 and looked at it in the PLCO population, which included never smokers, not the NLST. And he could find no one, not a single out of 65,000 patients who met criteria that would breach that 1.5% need to screen rate. So that's published in PLOS ONE. Another important paper is Stephanie Kowalczyk's paper. Now, this was a paper that looked at the risk of people who qualified for NLST and who have USPSTF guidance to screen. And their lowest quintile, their lowest 10,000 patients only accounted, out of the 50,000 patients in the NLST, only accounted for the 1% of the mortality reduction. So even there, where these are sort of high-risk persons who formerly or currently smoke, that lowest quintile risk did not account for much of the that mortality reduction. Again, it's about mortality reduction. I'd add one last thing, which is if you move down to the 50 and 20 pack years and put that into the Tamamaga equation, put in the lowest risk patient. I urge you to do it. It takes 3 seconds. That would be somebody who's 50 years old who quit smoking 14 years ago and has barely the 20 pack year history. Their risk of developing cancer in the next 6 years is 0.2%. 0.2%, meaning 99.8% of the participants could only be exposed to harm. I'm not saying not to screen those people, and we do. I'm saying finding a cancer in that group is difficult. The way out here is probably not through risk prediction models. The way out here is probably through biomarkers. And here's where I think that it could make a big difference. If we had a blood-based biomarker or a radiomics biomarker, as Dr. Sequist pointed out, that really could differentiate the cancers that are spilling tumor cells into the bloodstream as opposed to indolent cancers that are not. Perhaps, Lecia, instead of screening them every other year, as you were thinking about, perhaps you wouldn't screen that group of very low risk persons at all, because we do know, and it's not that I don't sympathize, we do know that particularly in Asian populations, there is a small portion of those patients who turn up in our clinics that are 50 years old, never smoked, with stage 4 lung cancer, generally EGFR positive. But would I love to find those sooner when they're not stage 4? Absolutely. I just don't know that a risk-based model currently exists to do that.
Yeah, and when I appreciate that point. When I was saying before about how we don't have a risk model to really tell us about the true risk, I was thinking more of the non-smoking related. It's true that the PLCO model and some others focus pretty accurately on smoking-related lung cancer, but really I think that they don't perform well at all when we're talking about this newer growing type of lung cancer. And it's all a matter of perspective. Thankfully, it's a small number of patients that come into your clinic with stage 4 EGFR lung cancer, but it's the majority of the people in my clinic. So I feel, and we're just seeing younger and younger patients diagnosed with stage 4 lung cancer, and it is very aggressive disease. It is not an overdiagnosis, and they're dying. So we have to, obviously, when we're talking about the population, we have to balance the risks and benefits, but I think it is a major and growing threat that we need to have on our radar.
So from my standpoint, like just from a simplistic point of view, like I think Jeremy, you bring up about the models. I agree with everybody on the call, but I don't think models are really the future. I mean, again, these are just opinions of the panelists, right? But it is like what Gerard said, it is biomarkers, I think, right? And Gerard and I were just at a meeting, right, where there was a million different companies. The top is the best biomarker for screening, for lung nodules, for surveillance. We all know that's a hot topic, and that's a hot topic for good reason, though. Now we don't know which one's going to be the best one. There's a lot of companies out there working on it to try to find that sensitivity level to use it for screening, not just lung nodules, right? But I would say that I do think that's the future. I think that'll help with what Gerard's point of view about resource utilization, right? Of getting CT scans on everybody every year is probably not feasible, right? It's certainly not feasible in a value-based care system, which is why, for example, at Kaiser Northern California, we don't do colonoscopies, right? We do fit testing. So if you have a fit test that's positive, then you go into colonoscopy. If you have a fit test that's negative, you don't, right? And because of a resource utilization thing that a lot of hospitals may have to deal with. So with that being said, whether it's blood or urine, I just was on a conference where there's now urine tests out. But I would say that the paper from Nature in 2021, looking at 75 women, never smokers that had lung cancer. They were able to look at their genetics/DNA profiling, and they were able to tell you, and I'm not a pianist, but they were able to tell you, this is what I think is the most fascinating paper, and I still am looking forward to seeing more, but 3 different levels of aggressiveness, right? And so this would help you talk about risk. It would tell you everything, which nodule is overdiagnosis, like Gerard is saying, in terms of that GGO, that's overdiagnosis, maybe that will never kill you, versus the GGO that Lecia and I see that are a lot more late stage, right? We don't know. But they looked at the 75 non-smokers and they were able to characterize 3 different types. So piano, mezzo forte, or forte. And again, so the piano being the one that the GGO, the adno, and the non-smoke and the never smoker, that's never going to do anything, right? That's just going to continue to just get a recurrence-free survival of 10 years of 99.7%, right? And then there was that mezzo forte one that was actually more associated with EGFR. So we know that EGFR could be 50 to 60%, but not everybody has EGFR. And the mezzo forte was the medium aggressive kind, whereas like, yeah, that's EGFR and you could get stage 4. And so, yeah, you may want to act on that. Or yes, it is important to screen that population. And then lastly, the forte, which is the kind that we forget about, but we still, that Lecia probably sees more than, the rest of us see, but is the ones that just full blown Mets everywhere right from the beginning. And that's the kind that's very aggressive. And these were in lung cancer and never smokers that we could see that in. So clearly there's a whole dichotomy. And so I do think that biomarker testing, if we can see that, that I think that we'll see the benefit of not getting overdiagnosis or not.
I don't think that was simplistic, Jeff. That was beautiful. And, it makes me want to go learn how to play piano. Just a friendly amendment to that. I think that germline mutations are incredibly important, right? One thing, and again, I don't want people to take away from this webinar that I'm not a very active person in screening and want to be screened. There is some thought, though, that those very aggressive cancers, at least as we know it today, may pass through the ability to be captured by traditional screening tests. So that is, they grow so quickly that and spread so quickly biologically that the current screening tests aren't able to capture them. And I know that's a concept nobody would like to hear about, certainly not me, but we need to sort of think about how would we approach those patients with a blood test or anything else.
Thank you all so much for that vibrant discussion. I actually like to go on with one of the concepts that I think several of you have raised at this point. That's the concept of overdiagnosis, which is often cited as a major concern of screening individuals who have never smoked for lung cancer. While very challenging to definitively prove, overdiagnosis can be suggested when favorable stage shift and lung cancer survival rates are not accompanied by decreases in lung cancer-specific mortality. In routine clinical practice, this debate often manifests, as Dr. Silvestri was bringing up, when deciding how best to manage subsolid and ground glass nodules. On the one hand, a surgical resection could be undertaken and reveal a diagnosis of adenocarcinoma, for example. However, the counterfactual scenario might see a patient undergo serial imaging without meaningful change of the subsolid nodule and eventually die from, let's say, a non-lung cancer cause. Of course, the only way to directly study this would be to perform a resource-intensive and very lengthy randomized controlled trial, which would take decades to yield results. So in the absence of definitive evidence one way or the other, how do you currently think about the concept of overdiagnosis in the context of screening individuals who have never smoked? And for this one, I'd like to start with Yeon Wook.
So I think we all know that the concept of overdiagnosis is not confined to only lung cancer and never smokers. Even in the landmark trials and screening trials on other cancer types, reports a certain proportion of overdiagnosed cancer in the screening arm, which can differ according to how you define overdiagnosis. So I think the question that we would be interested in terms of lung cancer in never smokers would be how prevalent overdiagnosis would be if we routinely screen never smokers for lung cancer, and what would be the findings that can cause overdiagnosis look like in CT scans. So from the studies mainly conducted in East Asia, I think the answer would be yes. Overdiagnosis can be highly prevalent, and the finding that refers to overdiagnosis would be mainly ground glass nodules that are surgically resected before confirmation of a significant progression.
That was beautiful, Yeon Wook. I think that was that's what I'm seeing as I've gotten into this space more and more, and you know, a lot of patients, you know, here in the States that may want screening that we don't offer for if you're a never smoker will go to other countries and get their lung health CT scan. But I think you want to put it perfectly. The overdiagnosis, I think, is, I don't want to say overplayed, but it is. You're seeing a lot of that based on, again, all East Asian studies. And again, I can't speak for every country, and I'm not gonna, and I won't, but I will tell you that it is very common practice in certain Asian countries to a 4 millimeter GGO, a 6 millimeter GGO. I've had patients like that have come back. They will resect those, okay, without following progression. Okay, so that is where I think, you know, Gerard in some of the published papers may be looking at in terms of overdiagnosis, right? I think there's a good medium in between. I'm not saying that we should resect every little GGO that we see in an Asian, you know, non-smoker or a non-smoker female, any race, ethnicity. But I will tell you, I think that's leading to some of the overdiagnosis rates, because like Yeon Wook said, in an NLST, the overdiagnosis rate, even in a high-risk population, was still like 12%. And then depending on what you look at, Japan, Korea, or China, those are the 3 different Asian countries that have looked at lung cancer screening. Some of them only show an overdiagnosis rate of 18%. So it depends what your, you know, what the majority of your country or in that study is resecting or not. I don't think that we should follow everything for years and years and years until it continues. So on one end, I think there's the people that will catch a GGO on a screening test, and that they will continue to follow that forever for 10 to 15 years, and even if it slowly grows, right? 1 millimeter, 2 millimeters, keep on growing. And then who knows, maybe we don't know when that's going to pop up and just go crazy, right? Until we get a good biomarker. That's the one end of the extreme. The other end is we see any GGO, right? It would probably drive Gerard nuts, any GGO or any pulmonologist nuts, and they just go and resect it, right? Just go and resect it like mad, right? And that's what they do in some. That's the other extreme of overdiagnosis. And then there's a medium, I think, and that's what we're here to talk about, kind of, is try to get, how do we get a compromise between both sides that want screening for everybody, and then the other side that's like, you know, no, let's take a step back, let's do a randomized controlled trial, which will cost $300 million, blah, and take forever. So I think finding that impetus is like, is it a certain size that you get the GGO at? Is it a certain, if it grows 1 millimeter, is that enough? Or does it need to grow 5 millimeters? Or does it, you know, that's where we get the risk profiling. If you have a family history of lung cancer, and that's what we're trying to figure out. So I think a good medium in between will help mitigate that overdiagnosis. And one of those things, and I'm going to put maybe this is to be provocative, but I think the biggest risk factor that I look at and that we're seeing is family history. I think that would be one way to help mitigate the overdiagnosis. Be interested to hear what you guys think.
Well, this is Gerard. I would say a couple things. One, I would like to push back on Roger and Jeff's assertion that a randomized control trial would cost $300 million and take many, many years. I think resource utilization has to consider the fact that in East Asia, in the last 2 years in Taiwan, after the results of the talent trial were published, that they've screened over 50,000 patients, were able to accrue those largely never smoking patients in a short period of time. And when you think about resource utilization, I think one must think about the fact that if you implement screening countrywide in a population where the benefit's not been proven, you will go through that resource much more quickly than the cost of a randomized trial over a shorter period of time. So I think that this keeps coming up, that randomized controlled trials, and again, I stand by the fact that you need level 1 evidence to have a public policy for a population, largely of which most will not get benefit. So the idea that we can't do a randomized trial because it'll take a long time, and that might take a long time to show overdiagnosis, by the way, which only suggests maybe you don't need the randomized trial to begin with, because you probably shouldn't screen that population, is another consideration. But I agree with you about one thing, Jeff. I do think that people are resecting these GGOs far too aggressively and far too quickly. And there's data from Korea suggesting that the rates of surgery have gone up dramatically, and the rates of biopsy and surveillance have gone down. So that you know, and by the way, I think 18% overdiagnosis, 1 in 5 true quote cancers detected, is a high amount, right? And that's probably something you don't want to be doing. And The problem is not that we're getting this level of overdiagnosis. It's that the more you screen outside of the criteria, the more likely you're going to find these ground glass nodules. And I'm actually not sure, and Dr. Kim has got some data that he's probably going to share at some point. I'm not sure that just largely occurs in women. I think the rate of overdiagnosis may be equal in men. It's just that we're screening a lot more never smoking women. And so I think those are all issues. I agree with you completely that biomarkers might help us make a difference, but right now, I'm not sure that this argument that randomized trials are not necessary. We seem to find them necessary for everything else, Jeff. We found them necessary to prove that lobectomy and lesser resection were equivalent. Do you know how long that took, Jeff? You were probably in high school when the lung cancer surgery group published their data saying lobectomy was better. It took us 20 years to decide that it wasn't better, and now it's being implemented. So I'm not sure the argument of not doing a randomized trial holds water, either on a resource utilization viewpoint or a length viewpoint. I'll leave it there.
What about if we said, though, right? If you want, so I get it, Gerard, and most people think about it, lung cancer. You want to see a lung cancer mortality reduction, like you did in Nelson, or like you did in LSD. Not you. I'm just saying in general that
Right.
people. In terms of timing wise, right? So obviously we know that's going to take longer, right? The LST showed out, published 2011. They started that in 2004. Just like you said, and I agree, randomized controlled trial is good, but do the endpoints, right? I take it from a different angle. What about breast, colon, prostate, cervical? Why does nobody say anything about that? If you actually look at what the data for breast mammogram is and colon cancer screening is, it's based off of modeling and risk, not on necessarily mortality reduction. So why are we so crazy? Well, that's a thumbs up for me. But why are we so?
That. I just want to let you know I didn't do that.
Somebody keeps on doing the thumbs up.
Because your arm is here. It's Zoom.
Oh, I guess I'm a Teams guy. I'm more of a Teams guy. I didn't realize that, but like I think that for breast, right? Like the overall survival for stage 1 breast cancer is 99.9%, right? And we catch a ton on breast mammogram, DCIS, everything. We chop those out, right? And we do all sorts of things, but we don't have a big qualm about it, right? Like in terms of overdiagnosis and all these things. Same thing with prostate, right? You can, but why in lung all of a sudden are we holding that standard up like differently, almost like the stigma, right? I'm not saying it's only stigma because this is maybe this is the stigma. I'll be provocative. Maybe this is a stigma that, yes, I agree. We got to get lung cancer screening in the high risk smoking population under control. That's for sure. We know we need to do that. We have a long ways to go and we really need to be focusing on that. But I do think that it's almost like another stigma for the never smokers. It's like, geez, this is another group that, we need to, that I think is like stigmatized in a way that's like, well, you're going to live forever, right? Because you even though if we take that out, but in reality, that's kind of what we want, right? And that's why breast, we don't go back and say, well, breast, we should only screen you. If anything, breast is going down, or they're screening even earlier now, right? And there's this whole debate about breast MRI, and I've had friends that have been saved by the breast MRI earlier, right? And I think Katie Kirk will talk about that, and with dense breasts and things. So I do think that there's like a double standard a little bit, Gerard, that we're seeing that that we don't see in breast or in colon, and those are great screening tests, but they're not really based on a lot of survival data.
Well, I think colon is, and the PLCO proved that. It was the only one of those 4 cancers that it proved a really strong benefit. I actually think there's an argument to be made, and people will make it, that the mistakes that are made in breast cancer mammography shouldn't be translated to lung cancer, and that there is a substantial rate of overdiagnosis in the breast cancer population. I don't think it at all has anything to do with stigma. There is an additional thing, Jeff, with you as a surgeon, I would say, which is this. I've had family members go through 3 or 4 breast cancer biopsies, the same person, and never having been diagnosed with breast cancer. And as anxious as it was, and as painful as it was for the family, the risk of dying of a breast cancer biopsy is wholly different than a patient undergoing thoracic oncology. Not maybe in your hands, but we do know 2 things. In all the randomized trials of high-risk smokers, the rate of resection for benign disease is 20%. 1 in 5 thoracotomies is done in one of those patient populations. We also know that even for low-risk patients, the mortality of lung cancer surgery, even if you argue it's 1%, right? Like, you are exposing people to risk who may not even have cancer, but if they have cancer, it may be an overdiagnosed cancer. And so, you know, like, I get it. I get that, you know, and then the last thing I'd say is the modeling stuff. You can't model something for which you don't know there is benefit. You can't model that. So modeling, this idea of modeling family history, when we don't know if screening people with family history reduces mortality, it just doesn't compute. It's like doing cost efficacy analysis without proving effectiveness, right? It's just hard, man. And I know people don't want to hear it. I don't think it's stigma at all, though. And by the way, the fact is we're currently, at best case scenario, screening 20% of the population who we know will benefit the most. And so I wonder whether or not, you know, concentrating on that population is as or more important than putting a screening service into effect for which we don't know whether there is benefit.
I have just a couple points to add to some of this conversation. One is that I think it is possible that by delinking lung cancer screening from this smoking, very strict smoking questionnaire and requirement, it actually could reduce stigma for all. If it was something that everyone did, like colon cancer, turn 45, everyone gets a colonoscopy, I guess, unless you're in Kaiser. But, you know, I think it obviously we have a lot more studies to do, but it is possible that making it more democratic will actually reduce the stigma. And then the second thing I was going to say just went out of my head. Oh, about the complications. You know, I think when you look at the trials that have been done and you're looking at, you know, benign resections and rates of complications from biopsy in people who didn't have cancer, it's really important to sparse out the people who did have cancer from that. Because like if you look at Brendan Stiles' publication, a lot of the pneumothoraces and the problems with biopsies were actually in people who had cancer. So that's not like a risk of the screening. That's a risk of lung cancer treatment and diagnosis. The people who actually had benign nodules had very, very low risks of complications. And I think these two things often get conflated in our conversations. I don't know if we can update our terminology, because there's seeing something on screening and then there's acting on it. And both of those are together a little bit different, and maybe overdiagnosis is not necessarily the term that we should use to encompass all of those. You know, there certainly is overtreatment of some benign lung cancers, but that has to do with more what happens after the screening, I think, than the screening, the act of screening itself.
Thank you all for the robust conversations. Really, really fascinating. So I just wanted to bring us to another question. On the heels of the talent study, which had been mentioned, I think, by Dr. Silvestri earlier, additional prospective cohort studies are currently underway in the United States, including the female Asian non-smoker screening study, which has nearly reached total approval. Which aspects of these studies do you find most interesting, and how, if at all, do you think the results of these observational studies will influence your clinical practice when they're eventually published? Maybe we could start with Dr. Kim with this question.
Yeah, I think all results will be very interesting. The detection rate, stage distribution, and risk, identifying risk of higher incident, who has higher risk in non-smokers. But actually, I have to agree with strongly agree with Gerard that we don't yet have evidence to prove benefit of screening in this population. So I would extremely like to see some data, if any, captured that on how we can identify the lung cancers detected or non-detected would have caused mortality. So maybe the thing I would like to see is be particularly interested is the incidence of maybe incident cancers that occur during screening rounds if they are doing multiple screening rounds?
I thought you were going to go with incidence of stage 4 disease. So there is one, it is one sort of indirect measure of potential for mortality reduction is a lower incidence coupled with a proportional increase in stage 1. So not a survival curve, because we know survival will go up in a population where cancers are overdiagnosed, but perhaps a lower rate of incidence of stage 4 disease. Hormuz Katke gave a fantastic talk at a recent meeting I was at, where he talked about other surrogate endpoints. And one of the things he talked about was using the control group of one of these trials as a better understanding of the need for having a randomized trial and using the cancers as the cancers still be randomized, but using the rate of cancer as the other surrogate. And I think there are people looking at other common trials. The thing I look for in these observational trials is I know that they're banking blood. I'm looking for whether we have a genomic signature on the cancers and what they look like radiographically. I know some of them are banking the radiomics. I think those are really important factors. And then, of course, getting a great description of capturing clinical demographic data, particularly as it relates to exposures, air pollution. There was a great paper on residents who live close to highways where diesel fuel is common and they have a higher rate of cancer. So getting that kind of information, I think, will help inform us about who we target trials towards. I don't think they're going to give us the information necessary, at least for me, to change my mind on who should be expanded within the screening realm of the U.S. Preventive Services Task Force.
So I love it. I agree with both of you, but I think I did share, like, if you think about it, right, is the lung cancer. So if we're just talking about lung cancer detection rate, I think so. What you brought up, Jeremy, I think it's fascinating, right? So there's only really the talent study that in Taiwan, and the FANSS study, Female Asian Never Smoking Screening Study, Elaine Shum, looking at 201 women, just no family history, no nothing, just 40 and above. 40 to 74 years old, and they found a lung cancer detection rate, right, of 1.5%. They were either stage 2 or 3, all EGFR positive, all got surgery or on due to a Dura trial or on treatment. But again, 1.5% detection rate. And just to remind everybody, as everybody knows on the call, an LST, Nelson, about a 1%, 0.9 and 1.1% detection rate. Then they followed those patients, right, over years and years. And then, yes, they eventually did have a mortality reduction that not surprisingly, you saw it more in women, and even though women weren't really included in those trials. So again, extrapolating I think we have to think differently than how we're thinking about for the NLST and the Nelson trial, because it's just in a different population. So I'm not saying that it has to be, what we're saying is no data for mortality, but I do think lung cancer detection rate is an interesting thing enough to start bringing that over to other studies, maybe preliminary studies, to find different ways. Because I think that if anything, the Female Asian Never Smoking Screening Study gets me fired up more. Which again, there's no conflict of interest, but we're because of our population of a lot higher never smokers, we're going to start our own. With regards, but I do think there's going to be specifics that could be different. So what we learned from the talent study, what we learned from the Female Asian Never Smoking Screening Study is, how do you gain information from that to now cater it to make it complementary or synergistic? For example, I think less than 40-year-old or 40-year-old women, or non-smokers in general, you're not going to see as much as you still will see more lung cancer picking up in an older age group. Younger than, say, the average age of lung cancer in a smoker, which is 70. But again, so like, for example, a 50-year-old and above, and not making it so wide and variable, and then a family history. So I think we could tailor that. I don't know if I'm making sense, but I think that there's just different things that we're learning that may not apply, that we may have to think differently than the classic 20% lung cancer reduction in mortality based on the NLST trial of high risk smokers in a mostly male population, Caucasian population?
Actually, Jeff, the one friendly amendment to that statement is that more of the benefit in national lung screening trial in Nelson occurred in women. In fact, if you took women out of those trials, they were negative trials. And so we do see a great benefit to screening in women. Again, these are women that are at high risk for developing and dying of lung cancer. So if you look at NLST, I think it was about a 7% relative risk reduction in men and about a 28% in women, and Nelson was even more. In fact, it was so much more that New England Journal had them present their subgroups, because they were largely men in that trial, separately if you read the trial. So I think there is a high risk in women who are heavy formerly or currently smoking. But I don't disagree with your point. I'm not saying we shouldn't look at this differently. I'm saying we should make sure that the evidence is reasonable.
So we are rapidly running out of time, unfortunately, and I want to kind of go a rapid fire style round here, and I'm going to close with a very challenging question, and I'm going to bring it back to the bedside. A lot of the stuff we've been discussing are really cutting edge research questions and risk models and the future of biomarkers and blood-based and radiomics and a lot of really great stuff. But as I think Dr. Sequist was mentioning earlier, all of us take care of patients at the end of the day. And one of the absolute most challenging things that we run into is when we are left with chatting face to face with a patient who has just been diagnosed with late stage disease, younger patient, let's say, who's never smoked a cigarette in their life, and they ask you, how could I have prevented this? What did I do wrong? Why wasn't I screened for lung cancer? And within the context of everything we just discussed today, I just like to kind of go around around all the panelists and just tell us all how you actually have that conversation with the patient face to face. For this one, let's start with Dr. Sequist.
Yeah, well, as a medical oncologist, I do get that question quite a bit, and it was actually the frequency of getting that question that led me to a mid-career change to focus on screening instead of cancer treatment research. So, I think the way that we change the future so that other people don't find themselves in that horrible situation is through research. And I think we've had a vibrant discussion about the pros and cons of some of the different research strategies and whether we need a randomized trial. But without a doubt, we need more information. We need to better understand who's at risk. I think biomarkers do offer some promise in helping us understand when someone does have cancer, what is the biology of that cancer? Is this cancer going to be an aggressive one that should be treated as soon as it's uncovered, or is this an indolent behaving cancer that should probably be watched so as to reduce harms to patients? I'm not sure that blood-based biomarkers are going to be able to tell us as much about who's at risk for cancer and who should start in screening programs. So I think we have to remember those differences in biomarkers, especially if they're based on tumor material. They're only good once someone actually has a tumor in their body. So I think we definitely need more research to understand who is at risk for future lung cancer. And for the non-smokers who are at high risk, how can we get the data together to convince ourselves that regular screening programs can help because they're at high risk, just like the NLST population.
I agree with the CS points that the question we have to answer to the patients reflect the unmet needs, that the knowledge gaps we have. So we need many research technologies to narrow those gaps. And for the patients that the never smoker diagnosed that way, I do see quite a patients that are diagnosed in an advanced stage who have never smoked. And my answer to those patients are that our current medical knowledge and technology maybe are insufficient for now to prevent and screen this type of cancer you got.
Yeah, this is Gerard. It's heartbreaking, right? My dad was diagnosed at 47 and died at 53 of cancer. And I've been on the other side of that conversation, receiving that news. And sadly, it's made me better at having that conversation, which is heartbreaking. And to tell a family that they may lose a loved one is terrible. And I think I would combine what Lecia and Yeon said, which is, we don't yet know. First of all, you start with it's not your fault. You did none of this to yourself. And by the way, as it gets to Jeff's comment about stigma, I don't blame my 80-year-old smoker who had a pack of cigarettes put in his GI pouch when he was 17. I don't blame them for being addicted the same way I don't blame a diabetic who doesn't follow their diet. This is what we have to get away from. And so all of them, no matter what age, are facing maybe death. And so for us, it's important for anybody on this call who's working with a lung cancer patient to empathize with their situation, to tell them that you're never going to abandon them, that you'll be with them and care for them as much as you can, to tell their family you're there to answer any questions, to tell them we're doing everything we can scientifically to break through of this disease that I've dedicated over 3 decades to, and that I'm happy to say right now, the treatments Lecia is able to give our patients are so much better and so much better tolerated. So that's the way I have that conversation. Sometimes I think it resonates. Of course, sometimes I know that the families are in, complete shock. And so the message has to be delivered more than once. Yeah. Do I ever never want to see someone now that would be the age of my little sister who's in her 40s? No, I don't want to see that for anyone.
I think what I deal with patients like that, when I see that, and certainly I do see that, and that is a very common question. If whether it's stage 1, 2, or 3 that we get that are non-smokers that discuss like what could we have done, differently. I try to focus on it like I don't know if this is better or worse, but I love that it's not your fault thing, like what Gerard's saying. I think that's great. But I try to say that as I try to use it as a teaching moment. Whether it's outreach or whatnot. And I think the patients really, even if they're diagnosed at stage 2, 3, or 4, they can relate to that because they want to educate so somebody else could maybe get caught earlier that doesn't qualify for screening. And so what I kind of say is to patients here that are maybe on this call or to whoever is to be proactive about your health, right? And Gerard made a perfect scenario up is like, often these patients that are non-smokers that get diagnosed with lung cancer stage 1, 2, 3, or 4, they usually have symptoms. And I think that's what goes unrecognized. They usually do have a cough and they usually do have something. They may not have weight loss and bone and neck pain. That's a little later on, but usually they have something going on. And I think the key is, like Gerard brought up, okay, I have a cough. I'm a non-smoker, I get some antibiotics and it doesn't get better or it's still there. That's when you have to be proactive, be like, maybe I need an imaging study. Maybe it's not just reflux. Maybe it's not this. So what I try to tell patients is that, the idea is to try to get these caught earlier when it may not just, it may be nothing, but to keep following up on things. So it's like, well, let your family know this, let your family know this, let other people know that regardless of smoking, if you don't smoke, you have these symptoms, you should get it checked out, and ideally an imaging study. So I'm pretty aggressive about it. Now, again, that may not be the right way that everybody needs to do that, but I do think trying to tell people, no, just go in for an imaging study. It's been 4 weeks. I'm concerned. And you don't have to get a CT scan. You can at least even start with an x-ray. Even though you may not catch everything, you may be able to catch something and then to a CT scan. So I try to do it from a educational kind of, point of view.
Well, with that, we are just past the hour, and I just wanted to thank all of our panelists who've been so generous with their time today. Multidisciplinary panel. I certainly learned a ton, and I'm confident that all of our attendees learned a lot as well. So thank you all very much for attending. Thank you for participating. And just as a reminder, this webinar has been recorded and will be uploaded to our ATS Thoracic Oncology Assembly website at a future date. Thanks very much.
Thank you to all the participants.
Thank you.
Thank you.
Thank you.
Thank you.